Good afternoon or good morning, depending upon where you're joining us. My name is Russell Hendrickson. I'm the CEO here at Practical Data Solutions. Thank you for joining us today. With me presenting on effective visualization healthcare data with budgets, benchmarks, and targets is Scott Everitt.
Hello, Russ. Thanks for having me today.
Thanks, Scott. So, you might be today, many organizations, building dashboards, most are, and integrating data in some cases can seem very easy. Here's an example of a dashboard that includes budget data, and you can very clearly see on the right side of the screen, performance, blue and green. It looks fairly simple. Another sample dashboard here, this is right out of our dashboard library that we have. Many of our clients are familiar with this. Looking at scheduling operations and just putting in targets. So you can clearly see where is your performance against an internal target, fairly clearly indicated against a line.
And I think what's good here, Russ, as well, that helps the communication is it's easy to see areas where you want to be above the line and where you want to be below the line when you look at the green arrows that are out there. So it's not even so much as taking time to interpret it. Everything is communicated clearly and quickly in this type of visualization.
And, I have one more that I want to sort of lead off with. Here's an example of integrating external benchmark data from the HFMA. This dashboard, less so much of a visualization, but clearly shows the HFMA map keys that we're using. We've got some internal goals and then our performance against those. And, very clearly sort of red X, green check. Are we hitting or missing against the benchmark and against our organizational goals? And today's topic really is, well, how do we make sense of this? How do we start to break down and look at different areas? And what we're going to do today is just share a little deeper about benchmarking and why we might want to benchmark.
So benchmarking obviously is something that our clients do talk to us about constantly, and it's something that they find important in their organization because they have the tools to be able to look and see how they're performing in certain areas and in certain key measures, but they want to add a little bit of context to that. We know what we're doing, but is that good? And so benchmarking is a good way to help kind of assess that performance and compare themselves to understand why they may be similar or why they may be different to other organizations that are out there. And benchmarking is a good way to determine areas where they may need to focus in the coming years strategically so that they can set goals around these particular targets that they want to set because there are areas in which they want to perform up to the benchmark level or even higher.
So, the question might lead in is, why don't organizations benchmark? Why don't we go out and benchmark and work with data? This is a question I'm asked to probably just about every meeting I have, whether it's with a PDS customer or a potential client. Do you offer benchmarking services, or what benchmarks do you work with, or where do we get benchmarks? And oftentimes, the question I ask is, well, what are you doing today? Well, we don't really benchmark. Well, why not? Well, we can't get good benchmarks. There's not a lot of good benchmarks for our organization, or the way they calculate a particular metric doesn't match with our standards within our KPIs that we're managing to. Is just some of the examples of what I hear. Scott, what do you typically hear?
A lot of what I hear that makes benchmarking difficult is just there are very high costs associated with it. Getting the external benchmark can be expensive, and it can be kind of prohibitive that way. In addition to that, a lot of the services that provide these external benchmarks want to incorporate our data in with it as well. And so the time and effort to fill out these surveys is just another thing that has to be done. But it's kind of a line that you have to walk to determine how critical is it to want to add this context to the communication that's out there. So with that, we'd like to move on by taking a survey for the participants and let us know how effectively would you say you're utilizing benchmarks in your reporting and communications that are out. All right, it looks fairly kind of like what you would expect to see. It looks like most are using some benchmarking in their reports and communications, and that's not surprising. There are some benchmarks that are fairly easy to get and standard and quality benchmarks, and then there are others that are a little bit more difficult, but this is about what I would expect to see. So, a lot of times when we talk about benchmarking this way, though, a lot of times people don't want to benchmark just because benchmarking can be scary. It's scary the first time you roll out this measurement of your organization's performance to executives and physicians, showing them where they are. And so we kind of have a perspective at PDS of how to take benchmarking and move it to be more effective to driving change within the organization. And the way we phrase it here at PDS is we generate light, not heat. what we're trying to do is we're trying to add context and show how we're performing compared to others. And in doing so, we're trying to identify opportunities and outliers. We're not trying to use this as embarrassment. We're not trying to incorporate punitive measures with performance against benchmarking. We're just trying to show where we stand so that we can take underperformance, identify it, and present it as an opportunity for maybe low-hanging fruit or additional growth in the organization. And so when we do that and provide incentives, we find that we get a little bit better result with what we're trying to do there.
Breaking that down, we like to think in terms of levels of benchmarking, and this sort of levels comes out of the usage of analytical tools and organizations, kind of ties in nicely with the sophistication of organizations and the types of analytics they use. But sort of at the lower level, trend benchmarking, which just about everybody does if they build out a dashboard comparing different periods of time, prior period, month to month, current year versus prior year, current quarter versus prior quarter, allows you to get perspective of how are we performing by giving it context to are we doing better or worse this month versus last. Going a little further, though, in first place, we always recommend beyond that is to start with internal benchmarks. How do all the physicians compare to their department? How do all the practices, collection rates compare to the individual sites? So benchmarking internally is a great place to start because it really allows you to look at the bottom performers, the top performers, and the medians and understand where are their outliers. And then going to the third level is, of course, bringing in external benchmarks to understand how is our performance or how are we functioning compared to other organizations that are like us. And those are really the first three levels that we recommend organizations start with.
I think once you get a little bit past those as well, you can go up to the next level and look at multi-metric benchmarking, which is essentially looking at the interplay between measures that are out there and how one measure kind of leads to the other as far as correlations go. And then taking that beyond up to predictive analytics or modeling and what-if scenarios where you look at different variables and pair the potential versus the actual that's out there. So talking about this, we would like to move on real quickly to another survey. We'd like to talk a little bit about which of these types of benchmarking is your organization using right now in your dashboards and visualizations. And great, so it looks like there are a few out there using the more advanced predictive analytics, relationship analytics, but for the most part, people are utilizing internal benchmarking and trend benchmarks the most. A lot are incorporating some external benchmarks as well, but it looks like the internal benchmarks is where the bulk of the audience is utilizing these benchmarks.
So let's start here, what we're calling case study number one. Scott deftly named it Dastardly Denials. Why don't you start us off here, Scott?
Sure. So this is a case study where a client wanted to analyze denial rates, and denial rates is a very common metric that people want to look at, but they wanted to do it for particular denial types where they felt they were having a problem, in particular documentation denials, coding denials, medical necessity denials. And they had also incorporated some new procedures in order to, one, reduce the denial rates altogether, but two, look at how well they were appealing and getting recoveries on the back end for when those denials did occur. They wanted to be able to better understand how they were performing on that, but that can be difficult to do, particularly with denial.
So adding context here, we have on the slide not many external benchmarks. There are certainly external benchmarks for denial rates, but some of the more advanced type metrics like recovery after denial, recovery after appeal, not very many good benchmarks available, and certainly a lot of variation in calculations. You know, I know from speaking with organizations that are submitting to benchmark services, I've heard a few times, well, we submit it this way, we submit it that way. They don't really tell us exactly what the measurement is they're looking for, so we submit it the way we report on it. So the challenge with using external benchmarks, a lot of variance in calculations, and that's what we ran into with this case study here. And then certainly the other challenge is there's so many different denial and informational codes, getting them mapped out to some level of standards widely varies across organizations if we were to look outside for comparative benchmark points.
Yeah, so let's talk a little bit about this particular case where you can understand how there are some tough choices in denial reporting of what you want to do. A lot of people want to look at denial rates and try to understand, let's look at it matched or look at it unmatched. The issue you have is when you're trying to look at denial rates matched, meaning these are the invoices that were created in the month of March, and here are the denials that came across. What's our denial rate? those are great, and it gives you a very good look at it. But the problem that you have is a recency lag, where in the most recent months that you're looking, you have very low rates because a lot of the denials haven't been posted yet. So a lot of people don't like looking at that, and they look at it unmatched, where they're saying, here's the denials posted in the month of March versus the charges posted in the month of March. And that will help give them some sort of idea that's there, but there's not a lot of context, and those really aren't matched. And in areas where charges are increasing, particularly if they're increasing fairly dramatically, denials as a function tends to grow with charges, and so it tends to understate the actual rates that are occurring. So, when you're looking at denial volumes as well, you want to understand, are they looking at charges? Are they looking at counts? Charges can be duplicated if they're counting all denials, and if you're looking at counts, it can skew the rates upward when you have a lot of denials hitting on single charges. And then, again, we talked about the mapping of the denial reasons, and do all services do them the same way? So it becomes kind of difficult to look that way. So one of the recommendations we made when talking about this is, how can we tell how well we're performing and where we want to be? And we said, well, are you better than where you were before you put these implementations in place?
So one of the dashboard examples that's in our library that many clients really gravitate to that simplifies that looks something like this. Maybe not directly related to benchmarking, but just want to notice as you look at this dashboard, the denials are categorized into high and low impact, with then categories across the primary denial classification. That's done through mapping and rolling the data together. So we're really measuring apples to apples. We can't do the next column, understanding how we are performing over the prior 12 months versus the last 6 months. So by having some standards and mapping, it really drives then to being able to do that comparative trend benchmarking, which is what you're seeing in the second box. If you look down then into the middle of the screen, you'll see it in blue here. Denial rate is running at 15.60%. That's our actual denial rate over the last 6 months. And then our target was 12%. So we could clearly see we're not at where we want to be. So that's bringing in just an internal target. And then there are some comparative periods in addition to some more information. But down here in the bottom right, you can see what's the reimbursement rate when we have a denial versus when we don't have a denial, to really show the impact of that not being able to hit or get clean claims through the system.
So this is also a good report to show things like the recovery rates we're talking about, and incorporating, an internal cost. Everybody's cost of covering a denial is going to be a little bit different. And you can see down in the lower left-hand corner this recovery rate where you're taking out the cost to rework a denial to get a net recovery. That recovery rate is one of the things they really wanted to look at, and it's going to be difficult to get an external benchmark for that when costs of recovery, cost of labor, cost of overhead are going to be so dramatically different from location to location. So in order to attach the personal recovery rate and cost associated with that, that allows you to look more internally for that type of measure.
So let's take a look at how our visualization tool can handle adding targets or benchmarks into the tool. And here we're looking at the same type of information. This is in an interactive visualization. So, I can very quickly and simply highlight, one area of the dashboard. You'll notice the data changes. But if we start looking across the top of the screen here, you can see we've set our denial rate target at 10%. And you can see by and large as an organization, we are hitting it, most of the time. We've had a few months, but at least over the last 12 months, it looks like we're hitting it about 70-80% of the time.
And so this is what we talk about when we talk about adding the context to the visualization. So you can see quickly and easily, are we hitting the internal target that we have set, and is our trend going a little bit lower? But then the visualization tools allow us to do something like look not just as an organization as a whole, but where are our outliers that are out there? So you could see we have certain divisions that are not hitting their denial rate targets, and divisions that we probably want to work with. Even while the trend seems to be going in the direction we would hope for, they're not close to their target yet. Meanwhile, we may have more high-performing departments or divisions which may have behaviors that we want to emulate in different divisions as well. And the tools allow us to go in and look at these ones that are our better performers as well.
Yeah, and it's a great example. Again, here you'll see here where the denial rates are with the total charges, so you can clearly see which departments have fairly low denial rates in spite of high volume denials. We're up over here, some of our smaller departments, so we can just simply point and click. And you can see now it's both endocrinology and medicine. And if you look at our adjusted denial rates, you can see, we've had some real issues. A good part using that trend comparison, we can see we're heading in the right direction. So visualization making it very easy with that target or benchmark to understand where we're performing and where we're not.
So this is a good tool to utilize, utilizing these visualization tools to really get in and look at what's feeding into your rates that are out there as well, and looking at like the denial types where you're having your biggest problems, whether it's registration or coding, etc. It allows you to set more specific targets where your organization may be struggling versus where it's performing well. So let's talk about another case study that is out there, and this is a place where a lot of organizations will utilize external benchmarks quite a bit because there are very good benchmarks out there related to provider productivity. There's good benchmark, whether it's from MGMA or AMGA or whatever professional organizations you're in. We want to be able to visualize this productivity. Where a lot of the organizations struggle is, how do they incorporate that, and what are some of the things that they can do and some of the conversations they can have with their providers so that the providers understand not only where they are in context to where they should be, but what are some of the things they can do to move in the direction they should be moving?
So, we talk about internal and external benchmarks. I touched on this earlier. Let's break down internal benchmarks, right? Look, comparing the individual physicians in this case to their teams, to their practice, to their specialty, to a particular location or geography if they're in, maybe a more rural setting. Our goal here is to look at apples to apples and really try to understand who are our top performers and who are our bottom performers, and how do we model or find the drivers that will move the bottom performers up. So internal benchmarking, a great place to start.
External benchmarking then is a way for the practice to kind of compare itself as a whole against specialties across the nation, so that they can better understand where they're similar and where they're different. They want to maybe sometimes remove these local issues that may be feeding into this and really try to become a high-performing organization. Help them set goals to say, well, this is where we are, but this is where we truly want to be, and be able to utilize these external benchmarks as effective methods of communication within the organization. So for those who are looking to incorporate these types of benchmarks, I talked a little bit before about MGMA. Obviously, if you're an academic, the Faculty Practice Solutions Center has more academic-related benchmarks that can be adjusted for clinical FTE and things like that. And then different management consulting firms have good benchmarks that they can utilize, not just for productivity measures, but for a lot of different revenue cycle access type measures that are out there as well. But when you have these external benchmarks, let's show in the tools how you can utilize the context of these to have an effective conversation maybe with a provider.
So as Scott and I were preparing for this webinar, I thought it would be kind of neat to showcase, adding different targets and benchmarks, both internal and external, and have you understand visually through the tool how your perspective on performance changes, potentially from a physician's perspective, but it could really be in any of the benchmarking or any of the KPIs you're measuring. So, we're making the assumption we have a performing physician who's doing a good job, maybe doesn't have any benchmark or budget or target to context against, and we're going to kind of try to simulate maybe a conversation of the physician saying, well, I understand, we're focused here, I'm working really hard. Help me understand either how am I performing, am I doing what's needed, or where are there opportunities to improve. So as a physician, I might look at this and say, well, my RVUs are fairly consistent, so clearly I'm performing. It's not like I'm, doing good work one month and not doing good work the next. So Scott, as an administrator, how can you help me understand, since there's no context here, this is just what I'm doing, how can you help me understand how am I performing against the organization's goals or some of the new targets that I heard we're rolling out?
Looking at the provider's actual productivity is the start, but let's incorporate maybe an external benchmark so that we can show, well, this is where the provider sits, and say, okay, well, here you're performing, you are fairly consistent, but here's the median 50th percentile benchmark, and you're performing a little bit under that. But is that fair, really, to the provider? Because this provider may only be 80% full-time provider. What happens, let's adjust the provider's work to look at how the provider would stand with their RVUs if they were at a full FTE. And so you can see here, this provider's work then is meeting that standard of the median benchmark if they adjusted for the clinical FTE.
Excellent. So then we might say, well, I've heard as an organization, I'd like to know, am I performing where my department is or the other physicians in my specialty? So we can now add, just dragging in here from the analytics, we can see that this physician is performing, potentially just below the median or their peer group, which overall still might not say, well, they're almost hitting the external benchmark, they're at sort of the 50th percentile, but where is there an opportunity to improve or perform? And in the example here, potentially maybe the organization just said, we don't want to be an average organization. We don't expect that we're better than other organizations. We want to perform above the median, as an organization, and I think that's a good goal. So maybe we want to set our target not at 50th, at the median of the benchmark, but at 65, the 65th percentile. And so now when you start to look at this position and even the department average, we can see there's some performance gap here that could be achieved. And then a physician might even ask, and I would ask if somebody was showing this to me as, well, how do I know that's achievable? I'm working very hard. We're very focused. How do I know that's achievable? And then we could bring in context of, well, where are the top 10% of our physicians performing? And the answer here is, well, you can see that we actually do have, 10% of our physicians are performing even above that 65th percentile, which you'd expect or hope. So that does show potentially then if we can move this physician or motivate this physician to say we need to move you up, or to start to model best practices, understanding what our top performing physicians are doing. And so I think this really illustrates having both internal and external benchmarks, being able to stratify where this physician falls. We might not actually show it to a physician this way, but when Scott and I were working up the webinar, I found this really fascinating that it really does sort of, by bringing context to that original chart of performance, really does change your perspective or help you to understand where there's an opportunity to improve.
Right, and a lot of times when you have, and you can see this, the provider's next thing will ask, well, I'm working really diligently, I'm working as hard as I can, there may be some other things that I can do, but what are these other providers doing in order to hit these targets, and where maybe am I lagging a little bit behind? And so you can deliver individual physician visualizations, reports like this, where they can look and see, well, from the standpoint of performance, your work RVUs are fine, but there may be issues with coding or the clinical fingerprint where they lag a little bit behind that can incorporate some changes and some training that will help them to perform a little bit better that way, or even charge lag where they're just flat out not getting credit for some of the things that they've done in the most recent reports because they're still sitting out there, or number of appointments versus the others that are out there. These are all things which feed into the productivity, and a report like this incorporates all three of the types of benchmarks that we've talked about so far, the last month, the current month, a comparison to a 6-month average. So we have the trend benchmarks in there. We have the internal benchmarks or internal targets of where we want to be, as well as external targets like the work RVU or coding benchmarks are all incorporated. And the provider can look at this and see red, yellow, green and know immediately where they're performing and where there are gaps that they can improve.
And what we've done here is, we talked about the physician's performance. We were measuring the department average and the benchmark and the percentile. This, again, is a dashboard you may have seen if you're a PDS customer or if you've looked at some of the tools and the services we offer. This is what we call our performance opportunity dashboard. It allows us to look at each physician in context to a department or a peer group, as well as then bring in appropriate external benchmarks and start to predict then, as we talk about higher levels of benchmarking, where are there opportunities and how do we quantify that cost? So Scott, do you want to break this down a little further?
Yeah, let's go ahead and split this up a little bit so it's a little bit easier to see. What we're trying to do with this is incorporate what we know and then just project it out to what could be. So this is what is happening. We can look at the activity by provider and see their total annual RVUs for the last 12 months, last 6 months, whatever period you want to look at. And then look at their annual collections as well and determine here's their average collection per RVU. And then you can adjust per clinical FTE, and then you can calculate an imputed clinical FTE. Well, this is what you said you are, but this is what you are in comparison to your peers as far as your productivity goes. And so looking at that, and then you can compare that to a benchmark RVU, both internal and external, and you can see by looking at a division or a specialty like this, the internal benchmark is already calculated for you and the external can be brought in. We can then project this out and say, well, what would happen per provider if they were to perform at these different levels? And so you can see here, based upon, we know their collections per work RVU, We can say, here's the financial opportunity that exists from a simple 5% RVU increase. Or here's the opportunity that exists if you were to perform at what you reported your clinical FTE to be, or if you were at the division average, or if you performed at a specialty average. And you can see right away that there are financial opportunities, or essentially a cost of doing business the way that we're doing, that these are unrealized financial opportunities that are sitting out there.
One of the things that I like about this is, the flags really highlight where there are large opportunities or where the bottom 10 or 20% potential gains are in terms of the total dollar volumes. And just sort of looking through, you can kind of see, if you look across the rows, Andrea White jumps right out at me, as well as Warren Gray, just because there's so many flags in their row, potentially saying if we can move this person up, there's some real revenue here. Even if this is theoretical, even if this is, at best practice, we may never be able to achieve these numbers. When you start to see, hey, if we could move somebody up and there's $218,000 over 12 months, what if we could do 25% of that? What if we could do 10% of that? Still becomes a significant number. And we've had many organizations managing performance and just trying to drive, how do we move the bottom 10% up? And in doing so, we can turn an ROI. Taking that same information, I like to show it again in a visualization tool, show the interactive capability through the tool. And so what you have here is a web-based visual version of the same type of dashboard, showing a summary across the various departments, which of course we could filter across and pick different departments. We see the physicians. This is that current activity box that Scott was just breaking down. And then over here we can start to see where are the physicians with the largest gains without having to use the flags. I can simply point and click, highlight, all the physicians that have maybe more than a $20,000 potential improvement, and right away the list starts to filter through where we see what the opportunity gains are. Or we can look through and we can look and see where are the opportunities, moving them to a division average or to the adjusted benchmark. And right away you'll see an outlier jumps right out here in this data set, Gary McHenry, with a lot of opportunity. So the visualization, is just another way to interact and a different way to view, but it makes it very easy to start to see where those outliers are, and then we know where we want to focus, right? Moving the bottom 10 or 20% up can yield 80% of the performance opportunity.
And really identifying outliers is a big success factor in incorporating benchmarks, because these outliers are the ones where like Russ said, your greatest returns lie. And so if we can utilize tools like this to get in and filter on these outliers, it's really going to help us as an administrative staff, in addition to helping those providers where the lowest hanging fruit lies. So let's take incorporating these to the next level, where we want to look at, predictive analytics or modeling. We want to look at being able to understand not just what is happening, but what could potentially happen. And we just did a little bit of that, but this next level incorporates more multi-metric benchmarking. And we look at this a lot of times with clients in areas like payer contracting and clinical access, but the biggest one right now is in physician compensation. And what's going on right now is a lot of clients are moving their physician compensation to base it more and align it more on how they're going to be reimbursed by payers moving forward. And as they've looked at their current plans, they've seen quite a bit that salary is not always aligned with the productivity. They have undercompensated providers who are high performers, and they have overcompensated providers who aren't meeting the goals or even the costs that their salary meets with their productivity. And so they're looking to really modify the compensation plan to align these measures together with the organizational goals and the reimbursement structures that are out there.
So in this case, we're using the current comp plan to become the benchmark, and we might model not just one plan, but multiple plans until we find the right plan that offers the right mix, and we're going to show you a little bit of that. But in this case, we have to sort of fix what the current comp is and then model multiple future plans and benchmark them against to understand where and how the changes to a particular plan would impact the organization. And this is long before we could even potentially think about rolling it out. So let's look at that just a little closer here. And one example here, and Scott, while you're talking to this, I'm going to pull up a visualization.
Sure. So this is an area we talk about with multi-metric benchmarking, where we brought in benchmarks for salary percentile and work RVU percentile, and then just done a scatter plot. And in looking at the scatter plot, you can really quickly and easily see that we have some providers who are high performing and low compensated, and these are ones that we're going to have to modify the plan in order to keep, in addition to ones who are very well compensated but may be underperforming based upon their compensation. And these are ones that we're going to have to move up into that level to justify their compensation by making them more productive based upon how the organization is going to be paid.
Excellent. And again, through the visualization, this is the same scattergram. We've got productivity and then salary. So what we're looking for is physicians that are low on productivity, but potentially being paid more than physicians that are higher on productivity. And through the tools, whether I just point to the dot or I want to highlight a section of where physicians are earning, we can very quickly start to see what departments, what specialties, and how they're performing. So it makes it very easy here.
So looking at a graph like this is great, but how do we take this to the level we want to get to where we can say, well, this is what is happening. We want to look at what could be happening or what will happen when we change the plan and model that out.
So we could do it through a visualization, but for purposes of this webinar, I think it's easier to look at the data itself. So what we have here now is the current blue is the current compensation, and it's broken down by all the physicians, and we could filter through and look at a particular department or specialty. So we're looking at across that, and then the yellow is one of our modeled compensation plans. We might have multiple plans that we've modeled out in our analytics. So what we can see then is the RVUs, the conversion factors, total comp, any additional incentive awards, which we might be adding, fairly common today. And then we can understand now, because we're benchmarking the current comp to the new comp, we can see if you look down here, right, those physicians that their comp would go down, assuming the same production, the same set of goals they're hitting today, under the new plan, what would be the difference in their compensation, trying to right-size some of that productivity and performance versus incentive.
Right, and this is a good way to, really quickly and easily identify winners and losers based upon the new variables that are going to be in the comp plan. We can easily predict based upon past performance where they're going to end up under the new plan. And here are the ones that we need to keep doing what they're doing and point other providers to emulate what they're doing in order to achieve the maximum compensation that's out there. And then these are the providers that may struggle under the new plan. These are the ones who, based upon the way that they do business, aren't meeting the expectations of productivity as well as maybe clinical quality incentives, patient satisfaction incentives. And these are areas where we're going to need to work with them individually to show them where they're underperforming specifically and what are some things that they can do in order to make themselves whole as the new comp plan comes into play. So this is a good way to do it individually, but if we wanted to speak to a provider.
So obviously we wouldn't want to show a provider, but this is an example of, a dashboard. This was a subject of a webinar we had just a few months ago where many organizations then are doing side-by-side reporting, as we call it. So here's your current plan over on the gray on the left side of the screen, how much you are earning today under the current plan. And once we've finalized what is the right plan, we're confident because we've modeled it and looked across, we can now start to publish that information out to the physicians so they can see not only if there is going to be a change in their comp, assuming they don't change their performance, what is the impact on that. And in this case, our sample plan is introducing some new clinic goals and incentive pools that if the physician was hitting those goals, you can see they're missing one of their patient access satisfaction goals, so they're not getting their full compensation. So that provides that opportunity by having that target right in their comp plan. If we improve, that's where you're going to see the change in your performance. So this is more of a visual of how you might want to share that information.
And this is good because it makes the entirety of the calculation transparent. It shows the provider the exact areas where the opportunity exists, and it gives them the ability to basically manage their own compensation to get to where they want to go. So we've talked a lot about the common benchmarks that are out there with regard to productivity, collections, revenue cycle. As the landscape of healthcare changes, you can tell that there are going to be more different benchmarks that organizations are going to want to be able to look at. Things like population health, and obviously cost of care is the main thing that's being talked about, and a lot of the measures that go into cost of care, like length of stay and readmission rates, are going to be areas where organizations are going to be desiring to benchmark themselves and make sure that they're among the high performers in those areas.
So to kind of summarize, benchmarking can really be powerful in driving change, obviously when applied appropriately, making sure you have the right context, and making sure that your visualizations and your dashboards really illustrate not only where is somebody performing, but potentially then bringing in the metrics around that to help them understand where there are gaps or challenges they can drive to. At PDS here, we say this a lot: walk, run, fly. So if you're not benchmarking, or if you're doing some of the simple things, evolve. Start slow, but work your way through, and definitely look at what both other organizations are doing and what's available. Certainly, we'd love to talk to you more about that. Scott, some other points you'd like to share to summarize here?
Again, we've talked a lot about this by looking at the outliers, and this is both on the positive side as well as on the negative side. We want to emulate the positive outliers, and we want to move the underperforming outliers up into department or divisional average. One of the great things about internal benchmarking is that average is a constantly moving target, and so even when you're a high-performing organization, you're going to find opportunities with providers who aren't necessarily meeting the divisional average, and be able to incentivize them to move up, either through attaching a financial opportunity or through just a desire to be a high-performing employee provider and get to the level to meet the organization's needs, as well as maybe their own compensation and ambitions that are out there.
Thank you for joining us today. We do appreciate your interest, and hope we will see you at future webinars coming up. Thank you. Have a great day.
Thank you, everyone.